So hello, everyone. We will be starting shortly. We're just giving a few more seconds for people to join. So thank you for joining today's webinar. Again, the title of the webinar is Strengthening Multiple Micronutrient Supplementation Monitoring Systems, Insights from Country Experiences. My name is Cecilia Gonzalez. I'm the Data for Nutrition Community of Practice Facilitator. Before we get started, I just wanted to remind you all, this is a webinar. All participant video and microphones are going to be muted during the presentation. We will have a recording of this webinar available on the Data for Nutrition YouTube channel immediately after the webinar, and we will also post the slides in the LinkedIn group for the community in the coming week. If you have any technical difficulties, you can try to log in and out of the webinar. And if you're still having difficulties, you can also use the chat box to message to Charmin Sultana, who can provide some technical assistance. For questions and answers, you can use the Q&A button to submit your questions. You can see that at the bottom of your screen on the menu. If you don't see it, it will be on the part with the 3 dots that says more. You can access the Q&A there. For the Q&A, you are able to see the questions that you put. You are able to comment on a question. You can also like the question to upvote it if you think that would be a good question to go through during the Q&A time. Without further ado, let me just share briefly about the Data for Nutrition Community of Practice. We have been active since 2019. This year, we transitioned from another platform to a LinkedIn group, and we are now at roughly 680 members on LinkedIn, and we are growing. Our goal is to provide opportunities to share knowledge, experience, and questions that are relevant to strengthening the nutrition data value chain, particularly with a focus in low and middle income countries. Today's moderator is Martin Mwangi. Martin is the program lead with the Healthy Mothers, Healthy Babies Consortium that is managed or coordinated by the Micronutrient Forum. Martin, go ahead.
Thank you. Thank you very much. Good morning, good afternoon, and good evening to everyone joining us across different time zones. It is a pleasure to welcome you to today's webinar titled Strengthening MMS Monitoring Systems, Insights from Country Experiences. As you have been told, my name is Martin Mwangi, and I am moderating today's session on behalf of the Healthy Mothers, Healthy Babies Consortium in collaboration with Data for Nutrition and DataDent. And we are very pleased to convene this discussion with colleagues from countries, academia, implementation partners, and other institutions. A little bit about the Healthy Mothers, Healthy Babies Consortium. We are hosted by the Micronutrient Forum, and we are a growing collective of more than 500 organizations and individuals. And our central focus is to curate the evidence that is around maternal nutrition and multiple micronutrient supplementation. And we therefore serve as a central platform for evidence, knowledge, collaboration, and advocacy in this space. With reference to today's webinar, as you know, antenatal multiple micronutrient supplementation is gaining momentum globally. And as more countries transition from iron and folic acid supplementation to MMS, monitoring systems are becoming a defining factor for success. Strong monitoring is what allows countries to track coverage, identify implementation bottlenecks, guide course correction, and ultimately ensure that scale-up translates into improved maternal and newborn outcomes. Today's webinar is therefore focused on a practical and timely question. How do we integrate MMS indicators into existing national health information systems in ways that are feasible, useful, and sustainable? We will explore this question through global perspectives, technical measurement considerations, and a concrete country experience from Nepal. Our objectives are threefold. First, to strengthen a shared understanding of how MMS monitoring aligns with national and global measurement frameworks. Second, to highlight practical lessons from countries that are already dealing with this issue and these challenges. And third, to identify priority actions and next steps that are needed to support countries as they look towards scaling up MMS. We are fortunate to be joined by an excellent panel of speakers who will bring complementary perspectives across policy, measurement science, country implementation. And so first we will have Rebecca Heikam, who is an associate professor from Johns Hopkins Bloomberg School of Public Health. We will also have Manish Gautam, who is a chairperson of Anweshan, Nepal. He will be followed by Melinda Munoz, who is an associate professor and researcher at the Johns Hopkins Department of International Health Institute for International Programs. And finally, we'll have Rijuta Pandav, who is the advocacy and communications lead at the Healthy Mothers, Healthy Babies Consortium of the Micronutrient Forum. After that, we'll have a question and answer session, and then we will close with some takeaway messages. I therefore encourage you to actively engage throughout the session by sharing your questions in the Q&A function and by participating in the polls when prompted. So with that, let us begin. Next.
Great. Thank you so much. Thank you, Martin. And I'm really thankful to get to speak to all of you and just kind of set the stage for this discussion about what does it mean to strengthen monitoring systems for MMS. Next slide. So the fundamental question that we're trying to answer is, how is it that governments, donors, and implementation or technical partners, how would they monitor the supply, reach, and adherence and quality of delivery of MMS at scale? And some of you are likely really familiar with the framework on the right, which has been developed by a collaboration of donors and country partners, talking about what are the key pillars for introduction of MMS. And in that pillar, it talks about needing to address policy and regulatory issues, financing issues, product issues, and delivery channel issues. And we'd like to say something is actually missing, though, that monitoring systems and making sure we're addressing monitoring systems at each stage of introduction and scale up is incredibly important. So we think there's going to be a need for guidance about what to measure at each stage in this process and how to integrate MMS into existing national monitoring systems. Next slide. So you see, we want to add this missing pillar and say, first, what is our objective? Next slide. So our ultimate objective is that we fully integrate MMS into national monitoring systems for antenatal care or through whatever channel is being used to deliver MMS in country. So it helps if we think about, in general, what sort of monitoring systems are currently being used for IFA in countries, because those are likely the same monitoring systems we have that we'd be adopting or using for MMS. So in most countries, we have a combination of administrative data and survey data. On the administrative side, we have an HMIS or DHIS2 and health coming through the health system. And we also have logistics MMS that are dealing with supply issues. On surveys, most countries have periodic household surveys. Even as we have questions about the future of the DHS, we have the mix, we have different national nutrition surveys. And in some countries, we also see doing facility-based surveys such as a SPA or a SARA, but looking at the quality of delivery in facilities. Next slide. So one thing is that we have these two, two that are asking this question of who is being reached, and we answer that through the HMIS and this household surveys. And then we have a question about are delivery systems working, especially supply chain, and we answer those through the logistics and facility-based surveys. Next slide. Now, each of these types of data, sorry, go back, have their own issues. So we think about administrative data and we think about surveys. We often have people who say, I only want to focus on admin data. That's the data that's most relative. Or I want to only focus on surveys because I don't trust the quality of the admin. But the truth is, both of these types of information are incredibly important and they are also complementary. Next slide. So if we think about it, the administrative data are what give us more real-time data, whether that be monthly or quarterly data. And even though there's data quality issues, the data can still be meaningful. It can give us signals and sense of trend as what is happening. And these are especially essential for people making program management decisions. And then we have the survey data, which tend to be periodic or lagged. So for example, they do a survey every 3 to 5 years, and they might even be asking women about the previous 2 years. So the data are not real time. But what's essential about the surveys is they're giving us population-based estimates, which means they're not only capturing the women who come to the health system, like the admin data does, but they're also capturing the women who are not getting the health system services, which means we can look at coverage. It lets us look at equity, and it also helps us with co-coverage if we want to look at different interventions together. And the survey data can often be a helpful check on the administrative data quality. Next slide. So as we think about this, as we think about how do we bring MMS into these systems of administrative and survey data, we have some challenges. One is the question of how do we contribute to broader information system strengthening? There are fundamental issues sometimes with an HMIS that by introducing one new indicator, we can't change those fundamental issues with reporting or quality or registers being distributed. So we have to think about how does our piece of this also contribute to the broader information system strengthening? Another challenge is that typically the nutrition community is not in control of these data platforms. So for example, we might introduce a change to the HMIS, but we have to wait for the process of those new registers being printed, being distributed across the country, and that can actually take years. I've worked in a context where it took 7 years to go from when changes were recommended to when they were actually being implemented across the country because it took that long for registers to roll out. It's also really important that nutrition is at the table early on in multi-topic survey planning, because if we're not at the table and we're not there when they're planning, we cannot introduce the changes. So this means that we have to be ready for the windows of opportunity there are to update these monitoring tools. We need to be able to ask clearly what it is and what changes or additions we want. And we need to be able to justify why and how the costs will be covered. We also need to start advocating as early as possible with both the program community, but also with the measurement and information system stakeholders, like the DPRS, the planning and who oversee the HMIS, and also groups like the statistical offices that support the national surveys. So these are things that are going to come up, I think, across this webinar. Next slide. And it's not just that we need to suggest changes, but we also need to address some technical issues so we are ready to make those recommendations. And Melinda is going to talk a little bit more about technical issues, but a couple things to highlight is first, keeping business as usual and just swapping IFA for MMS in our monitoring systems is not going to work. We know from work that people are not happy with the data they're getting on IFA. And so just like with MMS in general, we want to try to do better with our coverage, with our delivery. We also need to think about how can we do better with our monitoring systems and address some of those fundamental issues. Another challenge is that some of the methods that have been used for implementation research, which is what's been going on in many countries, are not actually feasible for routine monitoring. So when it comes to monitoring the HMIS, you cannot do pill counts or weigh the bottles and then insert that data into the HMIS. We have to be thinking about simpler ways that can be scaled, for example, including it in the registers or from women reporting on it as part of household surveys. And finally, there's a challenge that goes alongside the ongoing question about anemia treatment. We need to think about how is it that we're addressing anemia treatment in our data systems compared to anemia prevention and supplementation. So these are 3 issues. And like I said, Melinda's going to raise some more. Next slide. So another question then is, okay, so we know what our goal is, full integration. What do we need to be doing across this process at each stage of the scale up? Next slide. So similar to some of the other pillars, it's really helpful to have landscaping and assessment. So we need to make sure we're listening to and understanding the stakeholders involved in ANC and involved in IFA and MMS and understand what are their information needs. We need to deeply understand the current IFA monitoring systems and how it is we might be able to update those. And we need to be really clear on what are these windows of opportunity for impacting the systems. Then, just like in other parts of implementation, we need to design and test different changes to the monitoring systems and be ready to advocate for changes when the moment comes. And we have this fundamental question is, how do we monitor in the interim? And you're going to get some great examples of this with our example from Nepal next. But before that, on the next slide, I do want to share, so Anweshan, who you'll be hearing about from Nepal, also led, so we wanted to know, where is it that countries are right now with trying to address their monitoring systems as part of MMS scale-up? And Anweshan led a qualitative review of 13 countries in South Asia and Africa, and both did a literature review, but also reached out. And right now we see there's very little evidence that countries have really been addressing this issue of monitoring and how to adjust the monitoring systems. There's not a lot of clarity about how should the tools be updated, what sort of training, what sort of data quality assessment. And right now, in early stages of scale up, most groups are either using the existing IFA, but just changing it and recording MMS, or maybe they've created entirely different reporting systems or digital apps to address that. And this can be done both formally or informally. So it's really unclear for many countries whether they will continue monitoring IFA in parallel with MMS, or if MMS will totally take over. And then I think there's also a question in some countries about how do you monitor the private sector if the private sector is a player? So these are just some findings we thought, and we're going to go now. I'm going to hand over the next slide to Manish to give you a profile of Nepal. Thank you.
Thank you, Rebecca. Thank you, Martin. Good morning, good afternoon, and good evening, everyone. I'm Manish Gautam, a public health researcher based in Nepal and founder and managing director of Anweshan, a public health research and policy consulting firm. Today, I'll walk you through Nepal's experience as the country prepares to transition from IFA to MMS with a specific focus on the monitoring systems. So as you can see here, before talking about MMS, it's useful to understand the IFAS monitoring context that Nepal is coming from. On the left, you can see that IFAS has long been part of routine maternal health system where it's monitored through DHIS2, which tracks tablets distributed through ANC and PNC care, and surveys like Nepal Demographic Health Survey or SPA, or what we call as facility survey here. It also provides periodic insights, and the logistics are monitored through the public asset management system, or previously what was called the ELMIS. On the right, you see the delivery pathway. A woman who attends ANC, her expected EDD is calculated, and the IFS is started after the first trimester or at 16 weeks of reporting. She receives 30 tablets per visit. What gets recorded is tablets given and not the tablet consumed. Next slide, please. So, in order to understand MMS monitoring readiness, we took a systems-focused approach. We reviewed existing monitoring and logistics systems, national surveys, guidelines, and past transition experiences. We then held consultations with federal, provincial, and facility-level stakeholders to understand real-world recording and reporting practices. Findings were validated through a national consultations workshop, as you can see on the picture on the right, and which helped identify practical monitoring gaps and feasible transition options. Next slide, please. So in Nepal, as in many countries, as Rebecca told, monitoring systems are rarely discussed early in program design. Most of the attention goes to the intervention itself, while monitoring is addressed much later. HMIS revisions also happen only every 4 to 6 years, so systems are slow to adapt in Nepal. To be clear, HMIS is designed to track service delivery, not individual adherence. The issue is not that HMIS should suddenly measure everything, but that as programs become more complex, relying only on service delivery data leaves important blind spots. What this assessment did differently was to focus on how the overall monitoring ecosystem supports decision making. And through global discussion, we saw this challenge is not common across countries, and it's also not unique to Nepal. Next slide, please. Next slide, please. Yeah. So you can see what is the current system capturing and what it has missed so far. So Nepal's routine system is strong at tracking distribution. We know how many women receive tablets through ANC and PNC and whether stock is available or not, and the routine contact to the system. What we do not see in HMIS is actual use. So some of this is complemented by household surveys, but those again provide periodic and lagged estimates with their own limitations. So in day-to-day program management, when HMIS and logistics systems do not speak to each other in Nepal, distribution often becomes a proxy for use. And that gap becomes even more important when we are discussing and we are planning to transitioning to MMS. Next slide, please. So during this discussion, what are the options that Nepal has and something that can be replicated, globally on the discussions regarding the transitioning and the monitoring that could be done during those phases. Because MMS will not be rolled out everywhere at once due to many limitations, including the funding and procurement and all those issues. Monitoring also has to transition in phases. So from our analysis, Nepal has 3 realistic options. Option 1 is to use existing tools and separate MMS analytically by geography, or what we call in our HMI system as geographic code. This is fast, but IFAS and MMS get mixed in the same field, and during the analysis phases, it all becomes IFAS. Option 3 uses temporary stand-alone tools that's practiced widely in all of these kind of transition, or a vertical reporting system, which work for pilots but add workload and are hard to sustain. So what everyone agreed on is the option to strikes the best balance. Adding a simple MMS field within DHIS2 system allows a clear separation that fits nationally and supports scale up without confusing health workers. And also it can be analyzed later on based on its geographical code. And also that is a minimal burden to the health workers. But there are again questions such as how this will be used for anemia treatment. Because once the anemia is provided, twice a day, or what we call BD, then the tracking becomes entirely confusing, especially at the peripheral health facilities. And how will that be reported? And many more. But these options were discussed side by side, and through consultation, officials converged on option 2 as the most feasible and sustainable pathway for Nepal. Next slide, please. And this slides, brings in voices from the field where, because monitoring challenges looks different depending on where you sit. At the federal level, there is a clear concern about not overburdening health workers. Any tool change is seen as risky if not well planned. At the provincial level, people told us that they have strong experiences running such pilots, but they are often involved only after decisions are made and not during the decision-making process. And their experiences are not hard. At the facility level, health workers record what they are instructed to record. I think this is really important on how we instruct them or how we ask them to record. Some write MMS in the margins, as we have seen in a few pilot study and practices. But once reported at the DHIS2 system, everything becomes iron tablet. So across level, the message is the same. MMS needs clear, simple, system-wide monitoring guidance. Next slide, please. So what is Nepal doing differently then? One important difference in Nepal is that monitoring is being discussed early and deliberately. As shown in this framework for country MMS program scale up, monitoring is not treated as an add-on, but a core pillar or the 5th pillar alongside policy, financing, delivery, and supply. Nepal is already engaging program units, information system teams, and logistic units together and contributing to global discussions on why monitoring must be built into the transition roadmap. While changes to recording and reporting may appear simple, experiences shows these are often overlooked. The focus here is on using data to inform decisions, guide rollout, and strengthen accountability as MMS scales. Next slide, please. Next slide, please.
Manish, I think it's hidden. Why don't you just go ahead and speak out your points on the previous one? Sorry.
Yeah, thank you. I think that's it. And thank you all for listening and for the opportunity to be part of this important discussion. I would like to thank ECF, Eleanor Crook Foundation, and Johns Hopkins Bloomberg School of Public Health for the support. I now hand over to Melinda, who will take us through the technical measurement components. Thank you.
Thank you, Manish. And hi, everyone. It's a pleasure to be here today and talk to you a little bit about measurement considerations for scaling up MMS. Just a caveat that given the time, we're not going to get into study results or specific recommendations, but rather this is just to raise some questions for your consideration around some technical issues in monitoring MMS. Next slide, please. So when we want to measure iron or MMS supplementation in pregnancy, we're most interested in 4 pieces of information. First, which supplements did pregnant women receive? So did they get iron? Did they get iron folic acid? Did they get MMS? Second, how many supplements were they given or did they buy? Third, when did pregnant women begin taking the supplements? So when in pregnancy did they start taking it? And then fourth, how many supplements did they consume during their pregnancy? Next slide, please. So you already saw this slide from Rebecca. I'm putting it back up here again, just to remind ourselves that when we're talking about routinely measuring or monitoring MMS, these are the data sources that we have at our disposal. So HMIS, the logistics MIS, household surveys, as well as facility surveys, and they all have strengths and weaknesses or limitations. Next slide, please. Next slide. Okay, so I'm going to take the first 2 items together, the first 2 questions together. Which supplements did pregnant women receive, and how many did they get? So starting with which ones they received. So the challenge here is that while countries are transitioning from iron to MMS, there may be multiple types of supplements that are available and that pregnant women are accessing. So to give you just one example, a woman may live in an area that is included in MMS pilot or scale up. And so when she goes to ANC, she may be given MMS. And then she may visit her parents in an area that has not yet scaled up MMS. And she may go to ANC there and be given iron, right? So in that case, she gets both. Women may also be getting one supplement from her antenatal care and a different supplement at pharmacies. And women also may be getting MMS, but may be given iron for treatment of anemia if they're diagnosed as anemic. So you have this situation where women may be getting one supplement or the other or both during their pregnancy. And to really understand progress towards scale, we ideally would like to know which supplements women are receiving. Next slide, please. So how can we collect this data? So you've heard a little bit from Rebecca and from Manish about some challenges or thoughts around how do we integrate the type of supplement into the HMIS. The HMIS system is really well suited for collecting data on what is happening during ANC. So what types of supplements are being given to women who come for antenatal care, and potentially how many are women given. And in some settings, in some countries, this information is already collected for iron folic acid supplements. And so the question then is, as Manish and Rebecca laid out, do you need, what changes need to be made? So do you need revisions or redesigns to the ANC registers? Do you need new indicators added to the DHIS2 to be able to distinguish between MMS and iron and know sort of who got what? So that's in the HMIS. Household surveys are also well suited to measure this information. We can ask women what they received, and this is something that's already in the DHS. We ask women if they received iron. The issue there is that the existing questions are going to need careful adaptation to capture the types of supplements that women received, because we can no longer assume that they are only getting iron. So we need to ask them about the type of supplement they received, and we may need to provide visual aids to help women identify what they received. And here on the left, you can see an example of a visual aid that was developed in Ethiopia with Addis Continental Institute of Public Health to help women identify which types of supplements they received. Next slide, please. So the next piece of information is, when did pregnant women begin taking the supplements? This is increasingly recognized as important, really critical to the effectiveness of MMS, is taking it early in pregnancy, but has not historically been collected. Data on the challenge here is that data on gestational age are often inaccurate, whether they're collected in HMIS or in surveys. This may start to change with more widespread use of ultrasound. So many countries are scaling up ultrasound during ANC. And so with that, we may get more accurate early gestational age dating. And we may be better able to measure timing of supplement initiation. Next slide, please. Okay, and then the question that I think most people are really concerned with, which is, how many supplements did pregnant women consume? So this is sometimes referred to as adherence. So in trials, adherence is sometimes measured by pill count or bottle weight, right? So we count how many pills women have remaining, or we weigh their bottles throughout the trial to see how the weight changes as women remove pills. The challenge is, how do we measure adherence at scale when every woman in a region or every pregnant woman in a country is getting MMS, and we want to know how many they're getting during their pregnancy? Next. So there's been some experience using bottle weight for monitoring adherence in Jordan and at UNRWA clinics in Jordan, and that has worked well in that setting, and the paper has just come out. I think I have the reference on the next slide, but the generalizability to other settings really needs to be established. So is this a method that is feasible for implementation in other settings? Next. So at scale, self-report is often used to measure adherence, whether that's in surveys or through HMIS. And so self-report is just, we ask women, how many supplements did you take in the last 7 days, in the last 30 days, during your entire pregnancy? There have been some concerns that have been that people have about the accuracy of self-report based on our experience of measuring adherence to IFA, and I'll talk about that a little bit on the next slide. Go back, please. Yeah, there are also questions around recall period. So what recall period is useful? There's a tension between having a longer recall period and being able to measure adherence over a longer period, like the entire pregnancy, but maybe with less accuracy, versus having a shorter recall period, like the last 7 days, where women are able to tell you pretty accurately how many they took, but you're just measuring it over a short time period. In HMIS, if we want to measure adherence through self-report in HMIS, which has been, I think, is something that we're potentially interested in doing. There's concerns about selection bias and social desirability bias. So where only some women are included in the HMIS, and actually we can only ask adherence questions to women who are coming back for at least their second ANC. And they may or may not be willing to tell the health worker that they're seeing whether they're not being fully adherent to their MMS. Next slide, please. So just to talk a little bit more about the accuracy concerns, this is some data from a study that we did in Nepal a couple of years ago, validating the recall of iron supplementation in pregnancy. So in the graph on the right, you see on the x-axis the number of iron supplements that women reported that they had received over their entire pregnancy. So that's self-report. And on the y-axis, the number that they actually received based on observation of their ANC visit. And just quickly, what you can see is there's very little correlation between those two data points. And most of the points are below that red line, which in this case means that women were over-reporting the number of iron tablets they received by quite a lot in many cases. And in the qualitative work, women said that they found this question very difficult to answer, right? When they were asked to report how many supplements they received and how many they took over their whole pregnancy, they said, I have to remember how many days I did not take iron tablets. It is a thing from a year ago. How to remember.
1 minute, Mark.
Next slide, please. So the question is, can we design better questions? And so there has been a lot of work ongoing in this space, and I think maybe this is not the latest version of the slide, so the references seem to be missing here, but we'll make sure they're added in anything that we send out. So there's been some formative work on IFA and MMS coverage and adherence that's been conducted in Ethiopia and Bangladesh. And you see that on the left. So this is to try to design questions that women would be better able to answer both during and after pregnancy. And then there's some quantitative validation studies that have been conducted across at least 3 settings, Jordan, Ethiopia, and Nepal. And those results are starting to come out. So early results, I will say, are promising. And I'll stop there. Thank you. And I'll stop there and hand over to Rijuta.
Thank you all for the excellent presentations on in-country MMS monitoring systems. I am Rijuta Pandav, Advocacy and Communications Associate with the Healthy Mothers, Healthy Babies Consortium, hosted by the Micronutrient Forum. And today I will walk you through a global data and information management system for MMS implementation. Next slide, please. As you know, HMHP is a consortium of over 500 organizations and individuals, and we work with partners to improve maternal nutrition with a specific focus on adopting and scaling MMS in low and middle income countries. Our goal is to reach 75 million pregnant women each year in LMICs with high quality and affordable MMS by 2030. Next, please. So why are we interested in a global tracking system for MMS implementation? As you may know, in 2020, WHO recommended that MMS may be introduced through antenatal care, informed by rigorous implementation research. So several countries began to introduce MMS precisely in this manner. So there was a WHO requirement to monitor countries following their phases of implementation research. Further, implementers were asking, what are the key challenges and opportunities for introducing and scaling MMS? Governments were asking, what can we learn from other countries that have already started adopting MMS? And donors wanted to know about the financing needs of countries. Next, please. So stakeholders came together to understand how to track implementation research in countries by taking a phase-based approach. So the first phase was about creation of an enabling environment, the second phase about design and testing of effective implementation strategies, and the third was about scale-up actions informed by these results. This phase-based approach recognized that this process is nonlinear, iterative, and context-specific. Given that this was the first time the nutrition community came together to support the transition from an existing intervention, which was iron and folic acid supplementation, to MMS, with the intent to accelerate action across actors, this exercise went beyond merely collecting data, summary statistics, and information on MMS implementation activities, to sharing tools, resources, lessons learned, including from gray literature across regions and countries. So this led to the genesis of a global MMS implementation tracking mechanism that was visualized as an interactive world map of activities hosted by HMHB. Next, please. Next slide, please. So based on the data value chain, our first step was to identify and define priority issues and select relevant indicators to track progress for each phase. So for example, for phase 1, it was something like, is MMS included in the National Essentials Medicine List? Is it included in the national policy? For phase 2, it was about implementation research study, setting up an MMS task force at the national level. For phase 3, the questions were about costed operational plans and funding sources and supply and manufacturing sources. So coming to data collection, we developed a standardized online survey with a question for each indicator. After pilot testing, we sent this survey to all our in-country partners, requesting them to submit information along with supporting documents and sources. For curation, this data was consolidated in a single master file and organized by indicators for each country. We analyzed this data and developed country-specific summaries, classified these countries into phases that reflected their current implementation status. To complement this survey, we also conducted a detailed desk research exercise and developed more detailed country profiles for selected countries. Finally, to communicate this information to our stakeholders, we translated this into an interactive visual world map of MMS activities with dedicated individual country profile pages. And this map was intended to be used by multiple stakeholders to learn about country progress on MMS, identify gaps, and ultimately trigger action. Next, please. So finally, what does the world map deliver? At a glance, you can see it's a global snapshot of MMS implementation described by phases. You can see below there are country-specific profiles that link to individual web profiles with detailed information and dashboards on the MMS implementation status in that country. This map is very user-friendly. It's interactive. It's online. There are specific filters that answer key policy and program questions like, is MMS included in the EML? How is the MMS program being funded? And so on and so forth. The map is hosted on the HMHB website and is therefore available in over 100 languages. And you can select the language through a drop-down menu. And last but not least, this map is interlinked with HMHB's Knowledge Hub, which is a repository of over 500 resources on MMS and maternal nutrition. Next slide, please. So to ensure a data quality, we internally cross-check the data for accuracy. We also have a feedback mechanism to validate this data externally by partners. And from time to time, we make regular improvements to the annual HMHB survey informed by current needs. So this map was first launched in 2021, and in 2025, we revamped this map. We collect data from countries annually with real-time updates in between surveys, and this aggregated data is owned by the Micronutrient Forum and stored on HMHB servers. Most of this data is publicly and freely available and easily shareable. We also share restricted data on a case-by-case basis with stakeholders. Next slide, please. The world map complements other global tracking mechanisms. For example, UNICEF's NutriDash, which tracks important indicators like the number of women receiving MMS each year. We have a data sharing agreement with them for specific countries that allow their information to be shared publicly. And this information is very useful to us because of our goal of reaching 75 million pregnant women by 2030. This map is also linked to the WHO's website, which displays summary statistics on key maternal and newborn health indicators such as anemia prevalence in pregnant women, stillbirths, preterm births, and so on and so forth. Additionally, this map is also linked to very useful tools created by partners, such as Nutrition International's cost benefit tool that talks about the costs and benefits in transitioning from IFA to MMS, and Results for Development's roadmap costing tools to help government in planning and costing scale-up activities. Next slide, please. So the world map is useful to all kinds of stakeholders. So, for example, implementers can access research findings, gray literature, current implementation challenges, and so on. Governments can find resources for cross-country learning, policy documents, advocacy tools with links to NI and R4D's costing tools. Manufacturers can learn about the regulatory environment and supply chain issues, and donors can learn about specific financing needs of countries. Next slide, please. So as this map evolves, some of the key steps ahead of us are identifying and displaying the most relevant and used indicators by stakeholders. And we also want to communicate key gaps and challenges in implementation to drive policy and program decisions. Another emerging issue is that governments are interested in is supply chain. And so in the future, we would like to link with UNICEF's supply division website so that this information is readily available. And it's important information like how many MMS bottles were delivered to pregnant women. And so ultimately, with this map, we aim to activate countries and catalyze actions at the national level for MMS scale-up. So it's not simply an information management system, but it's also a tool to drive MMS action in countries. So with that, I end my presentation. Thank you for listening, and over to Martin. And finally, we would like to thank our donors and partners.
Thank you so much, Rijuta, and all the speakers, Rebecca and the others. We now have an opportunity to engage the speakers with a couple of questions, and I have seen one or two come through the chat. I think the first one can be handled by Melinda. Melinda, do you want to unmute yourself? And I would also like to request the speakers to put on their videos, include myself as well. Then we can have them address the question. So, Melinda, if you can, rephrase the question, at least in a way the audience can understand it, and then go ahead and answer it.
Sure, and thank you for, so the question is, how many days are considered adherent? So how many days does should a woman take MMS during her pregnancy to be considered adherent? Which is a great question because the answer for a long time has been, we don't know, we're not sure. This has also been true of iron, actually. For how many days does a woman need to take iron during her pregnancy to get a benefit? Not clear, but there was a review that was published earlier this year. I think Emily Smith was the first author that looked at exactly this question, did an analysis of trials and found that the maximum sort of benefit to the baby was found at 90% adherence. So if a woman took 90% of her supplements, with sort of a lesser benefit if she took 75% or more. And so now there's still a question for what will countries consider to be adherent, right? Will they consider women to be adherent only if they take 180 supplements, or will they allow for a lower bar? So that's a country decision. But in terms of what level of adherence is associated with a benefit, we're looking at about 75 to 90%. And so that's what we've been doing or using in our more recent validation analyses when we look at adherence.
Thank you very much. I think that's really clear. Manish, there is a question for you also from the chat. So you presented 3 options from Nepal as a country moves forward towards scaling MMS. Could you kindly, repeat those again for the audience? There's that request.
Thank you. Or Rebecca, do you want to address that? And then.
Oh, the options that you presented for Nepal. So you had the state option 1, option 2, option 3. I think recapping maybe what those were and why they're important. I'm happy to add to that, but do you want to go ahead and recap those 3 options of, continuing to collect data, but classify, maybe explaining what you mean by geographic classification, the first option?
Sure.
Yeah.
I think, but the question is, do we need to still continuously monitor?
Perhaps I can come in here. So the question is, any idea which option the country might be prioritizing? And I recall you mentioned that Nepal is prioritizing option 2, or rather considers option 2, which was add MMS in the register and also in the DHIS2. That seemed to be the preferred option. However, I believe work is still ongoing, but you can comment further, Manish, if I hope I've not taken it off direction.
Thank you, Martin. I think, we still, given the time that it takes to revise all of these tools and recording, reporting, and that it needs to go down at the facility level, one of the best feasible option is that DHIS2 on the online system, we can change it and we can create a field as MMS, which can be done more easily and effectively. And then I tell geographic code, there are each facilities that are assigned to that code. Am I audible?
There's just a little bit of delay, but you're good. Yeah.
So when I tell geographic code, each of these health facilities are then assigned with that code. So it is much easier when the scale up is done, inside a province, or let's say inside a district, or within a municipality or rural municipality. That way, even, in the recording field, if we have it as an IFA, and during the reporting phases, that can be directly done as MMS in the online system. So that is what I'm referring to. But on the first option, if you see, if we directly just do IFA and MMS, there might be a double counting, or the clarity might not be there. But even with option 2, there are challenges of if there are any dropouts or any issues like that, and how are we going to track? And the government is not yet clear. So as far as the last consultation that we had at what we call the Family Welfare Division here, they want to continue as IFA is. So 180 and 45, right, at the postpartum. So that's how they're trying to do. But with the anemia treatment, since it should be given as in supplementation or as a treatment, right? So during that phases, how are we going to monitor? That's still under discussion. Thank you.
Thank you very much, Manish. Rebecca, now turning the spotlight to you. So you highlighted MMS monitoring as a missing pillar in the IFA to MMS transition, and you emphasized the need for integration of this monitoring to existing system. Now, what kind of research or implementation research would be useful for validation of the MMS work? And while you're commenting as well, perhaps I could add, from a global perspective, is there 1 or 2 core MMS indicators that countries you think should prioritize within their monitoring systems?
Yeah, thanks. Those are great questions. Yeah, so we do know that right now the recommendation is doing this work in the context of implementation research. And I think a lot of research has been done about delivery. What counseling do we do? Do we do bottles? Do we deliver it in blister packs? Those kind of questions. But when it comes to the monitoring system, there are some really important research that could be done about how do we change the registers? Or Manish was just saying, does it make sense that do we have to change the register, or will we be able to, for example, really classify after people have reported this entire facility, we know it was MMS, or this entire facility, we know it was IFA? Well, those are actually things you can do implementation research about. Is that really feasible? If you make changes to the registers, are those usable? Are they feasible? Can they be added? And so really testing that before we go and make the recommendation is incredibly important. And then on the survey side, like Melinda was saying, we have to change questions. So DataDent has actually recommended some new questions that we could potentially pose to deal with some of the issues with household survey questions, but those actually still need to be validated. We haven't been able to do those, or we haven't done that in enough context. So there is actually research about the monitoring and how we do the monitoring. That's really important so that we make a really feasible recommendation to the DPRS, because again, it's not the nutrition community that controls. And so the nutrition community needs to make a really feasible, appropriate recommendation to the groups that are actually going to be making the changes in the monitoring system. Thanks.
Very well said, very well put. Now I'll turn to Rijuta. Thank you very much. You presented the global MMS map and data system as a complement to country and other reporting platforms. You emphasize that it's meant to activate action by making information available to actors. What are some of the constraints that you have faced in developing the map, from data collection to data sharing? Perhaps those could inform future efforts.
Yeah, that's a really good question, Martin. As you know, an exercise like this by the whole HMHB team and partners is a huge undertaking. It's very resource intensive. And given that HMHB works with partners in countries, we are dependent on them and what they are able to get from governments or their in-country projects. So this limits the kind of data that we're able to get from them. And also, for example, government approvals can be very slow in sharing certain kinds of data. And then also there are survey-related knowledge gaps. So for example, some of our in-country partners may not fully understand if we're referring to UNIMAP MMS or micronutrient powders, or what kind of micronutrients are given in which form. And so these are all valid concerns, and the steps that we can take in the future is to first improve our questionnaire to be very clear to partners, maybe brief them beforehand, on these knowledge-related gaps. We also would like to expand our partner base so we can get more information from countries and from more countries, and then also. Working through government approvals is always challenging, but when we have more direct government partner interaction, that can help facilitate data sharing and collection. Over to you. Thank you.
Thank you. And I think data for action as well, right? So that the data is not only collected for repositories, but also is used for real action by especially the frontline workers. Now, it's a pity that we have come, or we are almost at the end of our session, but I would like to take a few minutes to first, of course, thank my panelists, but also try to synthesize what we have learned today. So I'll do that briefly. First, on emerging priorities from the presentations and the discussion that we have just had, I think we are clear now that monitoring is not a peripheral activity in MMS scale-up. I think it is a core system function. Across global, technical, and country perspectives, several consistent priorities have also emerged, and I could try to name them. One, we have to integrate MMS, and I think that came very clearly from Nepal, integrate MMS monitoring in national systems rather than setting up parallel systems. There was also a question about options, and referring as well to the option that is more about integrating it in existing systems. Countries are clear that MMS indicators must be embedded within existing national health information systems, whether it's DHIS2, health information management systems, or even routine registers, rather than establishing other standalone reporting systems. This link will ensure sustainability of the platforms, but also ownership and routine data use. Two, there need to be clarity and prioritization of indicators. That was very well highlighted by Rebecca's presentation and also Melinda's presentation. There is a strong call for a well-defined set of core MMS indicators that countries can realistically collect analyze, and use. And these indicators must align with global frameworks while remaining adaptable to country contexts. And also, going to Rajuta's presentation, stages of MMS introduction, countries are going through phases. So at least the indicators should be able to be adaptable to these phases. And then finally, moving beyond coverage to data use. So monitoring systems must support decision-making, not just reporting. So countries want data that help them identify bottlenecks in adherence that came from Melinda, supply, but also we have had in other contexts, especially from Rajuta's service delivery quality. And countries want to course correct so that the issues they had with IFA don't repeat. As such, colleagues, we need to harmonize across partners, governments, donors, normative agencies, UN agencies, implementing organizations. This must be a priority because fragmented guidance and reporting requirements will increase the burden on countries and weaken data quality. So with those few remarks, I hope I have done some service to the presentations. There was a lot of knowledge. I cannot really summarize it, all of it, but I hope the slides will be available for download, or you can also go to the YouTube live channel and watch this webinar again and reach out to Data for Nutrition or HMHB if you want to reach to the presenters. Thank you very much for joining us and wish you the best for the rest of your day. Bye-bye.
Thank you so much. Great webinar, everyone. Have a good day. Happy holidays to all.
Happy holidays to everyone.